Hello everyone, my name is Sergio. I'm a surgeon at the University of North Carolina. This is a case of robotic inguinal hernia repair with sac abandonment. This is a patient that has cirrhosis with portal hypertension, MELD of 14, not going to get a transplant anytime soon with a very symptomatic inguinoscrotal hernia. His BMI is 39. It was containing several loops of bowel. He had been to the emergency room with incarceration episodes, so we elected to go ahead and proceed with hernia repair. We talked to hepatology. They thought he was optimized. So when we got a CT scan, did not show significant varices in the abdominal wall. So we elected to approach this robotically and abandoning the sac. So these are a great option for these large inguinoscrotal hernias. And we can see here, I'm incising the peritoneal at the level of the internal ring, peeling away the vessels, the cord structures. And once I can see through there, just taking the peritoneum at that level. Usually try to take it 360. Sometimes, the angle is not great or there's too much scar tissue, especially in that inferior medial part of the internal ring. There's usually where there's most scar. But I'm just peeling it off, and once I can see through, I'll go ahead and divide it. I always try to do a full 360 transaction. Sometimes it's really scarred down. I would just go ahead and start my flap as usual, but I try to do as much as I can. You can see their vast showing up there. You can be a little more aggressive now. All your cord structures are downwards. You can be a little more aggressive with care. Of course, the epigastrics are right there, so you just have to be careful. A little bit more there. Transaction. I did go a little bit too deep into the hernia there, which made this part a little more difficult than it needs to be. I would have done different. I probably have taken a little bit closer to me. But again, if you don't do a full 360, you can very easily go back from the top and do this part, and which is what I'm going to do right now here. So just taking a look, see where it's going to be a good time, good place to start the flap. I'll go ahead and start from right to left. I'm right-handed, making our peritoneal incision as usual. I'm going to go the dissection space of ratios first. Hand over hand spreading. I usually stop the flap a little bit higher on these cases because I know I'm going to need to recruit some peritoneum because I am going to have a large peritoneal hole to close. So I do usually start a little bit higher than usual just to make sure I have no tension and no issues closing the peritoneum later on. I think it never hurts to start higher. So I'm finding my way there down to pubis, which is right there. After I do that, I usually go space of Bogros, do that dissection. So I'm going to work a little bit more laterally now. Always with care here, I'm trying to make sure as much of the fat as possible goes with the abdominal wall, that avoid us going too deep and getting to the nerves. Connecting kind of both planes. Then you can see here I'm going to meet the transaction that I did on the flap very, very shortly, kind of connecting both dissection planes that I've developed. See right there, I'm starting to see through, that's the hole. I connect all the way through. And the medial part is the part that I haven't divided yet. You can see it's so easy when you can see from the other side as well. So that's why if I'm having a hard time in the beginning, very beginning to do the full 360, I just go from the top and I can have a much better view and take it from there without any, you can see how this was much easier than what I was doing earlier. Have a very good view from the cord, and now here I'm just gonna carry that dissection inferiorly. And again, it's very important to do a good inferior dissection because you're going to pull that flat bottom edge of that peritoneal hole upwards, and we don't want that to move the mesh at all. As you can see here, cleaning off the vas a little bit. I like to grab the plane that I'm developing and taking what's clear. You can see here pushing down the vessels. Yes, as portal hypertension, I want to make sure we get all the vessels. It's a femoral space. Continue to mobilize that vas. Usually this closer to the peritoneum, the safer you are here. So just follow that peritoneal downwards. You can see the triangle of doom there very well. Just making sure it's not leaving any fat there in the femoral space. Kind of dissecting now inferiorly below pubis. Trying to achieve that critical view. And gonna dissect on the contralateral side to see Cooper's on the other side. It's right there. I want to accommodate extra large mesh, so just creating the space for that. Yeah, and again, just peeling off those cord vessel structures away from the peritoneum. And if you're in doubt, just stay close to peritoneum. You'll be able to achieve the dissection that you need. You can see there, there's assessing how the flap is pulling up. I still need to do some more dissection there. See the medial umbilical ligament there for a glance. See the iliac artery there pulsating. Once we kind of finish that section, we put the extra large mesh. Make sure it's gonna move whenever I close that flap. Make sure I'm not leaving a corolipoma behind. There. Put a couple of Vicryl stitches just to fixate the mesh a little bit. And here's the peritoneal closure. I like to start always closing the flap first, and then I can figure out how the peritoneal hole is gonna close better. After the flap is up, that facilitated for me. So you can see there that there is no tension at all, even though it's a big hole. There's no tension when closing this. So as long as you do enough dissection inferiorly and you start a flap a little bit higher than usual, you'll be able to close this hole no matter how big it is, 99% of the time. So again, I think this technique avoided a lot of, it buys you time, that you're not wasting dissecting that hernia sac, minimize the chance of hematomas, I think, because, like that hernia sac dissection when you're down there in the scrotum, these big inguinoscrotal hernias can become a little bloody. So especially him with portal hypertension, I thought it was not worth the risk. I did advise him that he's at increased risk of getting a seroma, and really emphasize the importance of compression in the first weeks after the surgery. But you can see here, with the robot especially, this peritoneal hole gets quite easy to close. And again, there's no tension. It's not moving the mesh at all. I'm checking just to make sure there was no other holes left behind, and there weren't. Here we're just bringing the suture back on yourself.
Patient was discharged same day of the surgery. There were no liver complications. There were no postoperative complications other than a small seroma that resolved spontaneously, was asymptomatic, and resolved 4 weeks after the surgery. Thank you for watching.